we'll talk about a topic that impacts at least 1 out of 5 patients still. It's been decreasing over the years, but alkylating and platinating agents, between 1 in 5 and 1 in 4 patients will end up receiving one of these medications. So objectives today are just review the mechanisms of action, related adverse effects, and supportive care strategies for these drugs. And like the history of these agents, the first FDA-approved drug was 1954, but during the war, sulfur mustard was found to have effects on lymph tissue, and it shrunk tissues in lymph nodes of soldiers. From that, these pharmacologists at Yale developed mechlorethamine, which is a relatively unstable drug, but still available in some circumstances. And this was published. It was known before the war was over. It was published after World War II ended. And oh yeah, sorry, I have a little poll question there. Number of patients a year treating with these drugs. So there's 6 different groups. We'll talk about 15 different drugs today, but they really, it's kind of a diversity of science that helped these medications be discovered. And so anywhere from a monoamine oxidase inhibitor being screened for toxic effects, that it actually found anti-leukemic effects there. Biophysics, Linus Pauling in California was contributed to platinating agents being founded. And then just kind of rational drug designs with computer-based models, and then the NCI panels where they do thousands of chemicals a year to screen for toxicity. So a lot of different approaches to get to these drugs. So here's a relatively overview slide of the drugs. So 15 different drugs in these 2 classes. The 13 different disease-oriented teams use these medications. And so hopefully everyone on the call has something here today. They've been approved from 1954 to 2008. Bendamustine is actually, it was around 20 plus years before in Europe, before its 2008 approval in the US. And then we have number of patients treated, treatment plans would be roughly 220, and then number of patients treated is roughly 2,200 to 2,300 per year. The Cancer Center has 10,000 patients per year that are treated with chemotherapy. We see 30,000 visits for either follow-up or processing of cancer workup. And so it still impacts. It used to be much higher use for this class, but now with immunotherapy and cellular therapies, it has gone down, but it still plays a role, and anywhere from curative first intent all the way through palliative metastatic disease. Here's kind of spelling that out. There's about 700 protocols. I forgot to update this slide. So alkylating agents are about 15% of the core treatment plans we use, and then platinating agents are roughly 20% of the core treatment plans we use. Mechanism of action. So both of these classes work in a similar manner. You're relying on this nucleophilic attack to the electron-rich sites of DNA. So certain sites have better potential, like N7 guanine, for instance, is very, very electron-rich, and the nucleophiles attack that site readily. And so alkylating agent would be an alkyl group. Chemical platinating agent would replace that alkyl group with a platinum compound. And so overall, this is how all these drugs work. There's differences in drug tumor penetration. There's been some on cell penetration. But really the principles of kinetics and pharmacodynamics are what lead, as you saw in the first slide, like cyclophosphamide is well ahead of all the other drugs for reasons mostly related to its consistency and our ability as clinicians to watch the side effects cleanly. All right, so our next, which percent of these alkylating agents cause secondary cancer or have a warning for it in the package insert? So kind of 3 mechanisms how they work. They actually fracture DNA, so fragment DNA, they will end up with producing mispaired nucleotides. So you can see here the alkylating guanine with thymine has 3 hydrogen bonds, so it's actually more stable than the nature-driven CG bond. And then the molecules will bond within proteins, within intrastrand DNA, DNA to DNA, and so cause a lot of instability in that way. Those are covalent bonds and damage results. Okay, so the black box warnings. So we have 12 black box warnings for these 15 drugs, and we'll just kind of detail these kind of from head to toe. So CNS toxicity, ifosfamide, probably about every 12 months to 18 months. And this is kind of a key of this lecture, is that these adverse effects are not common, but they're horrifying. And so having a center that has a lot of physicians that treat cancer and has seen these effects is very helpful. So the encephalopathy with ifosfamide we'll see roughly once every 12 to 18 months. And we'll talk about that today. Pulmonary toxicity, so busulfan was the first drug ever to be shown to cause lung damage. It didn't quite reach the level of black box warning because it's really pulmonary fibrosis. That's kind of a late stage effect. Still very important, but not quite a black box like carmustine is, which has both direct lung damage and pulmonary fibrosis as a toxicity. Nausea and vomiting, so we'll still have probably 6 patients, even with a really good antiemetic preventing drugs, anywhere from 6 to 10 patients admitted with severe intractable nausea. And those are generally with really mega doses, like greater than 100 mg per meter squared of cisplatin sarcoma type patients. But they can be very difficult to treat, kidney issues, oral intake issues. So we'll still see that with the platinum drugs. Dacarbazine, the MOI type liver toxicity can happen all the way to fatal injury. Nephrotoxicity, cisplatin and ifosfamide are both can have direct kidney injury. Hemorrhagic cystitis, it can happen with cyclophosphamide, it can happen with temozolomide, but the black box warning would be for ifosfamide. With ifosfamide, you absolutely have to use fluids and mesna to treat it. The other drugs, you can kind of be plus minus. Myelosuppression is pretty much the whole group. Every single one of these drugs has myelosuppression as a warning, and important to watch that with monitoring. Peripheral neuropathy will show up as with cisplatin, where we can have dose-limiting toxicity with cisplatin. Then secondary cancers, it makes the black box warning for 4 of these drugs. Hypersensitivity, the most common hypersensitivity we'll see is oxaliplatin, which up to 16% of patients will have reactions. And then the last one is medication error prevention. Lomustine is given once every 6 weeks. And so the direction is to only dispense 1 dose at a time, because there has been overdoses if a 3-month supply of lomustine is dispensed, or even multiple doses are dispensed. So very, very key to avoid that overdose. So I won't spend as much time on the warnings, but kind of the similar theme, all organ systems are affected. So you can see with neurology, probably the most number of detailed warnings in the package inserts. Pulmonology, it's mostly direct toxicity and fibrosis, so there's that pattern. It's really tough with lung injury because often these injuries are delayed, whereas the neuro injuries are pretty much right away. Cardiac generally are upfront as well. Hepatotoxicity you'll see pretty early on. And then renal toxicity, heme toxicity, ID, derm, wound healing. Then the miscellaneous, quite a few, but as you'll see, like all 13 of the medications have secondary cancer as a warning. Hypersensitivity, infusion reactions, extravasation, which can be dangerous, and limb destroying are real advanced morbidities. So we have an extravasation guideline to manage all these, and I don't memorize it. I look it up right away and save it in, like there's an order set you can save in your favorites. Okay, so we'll kind of go through kind of systems, I guess, and talk about some of the case examples. BMT, we use these principles a lot to condition patients' marrows. And so we kind of like this for BMT, especially, melphalan, carmustine. Bendamustine not on here, but it's very similar, really prolonged naters. And that allows the space to be engraftment from a donor marrow. But as you can see, Cytoxan, cyclophosphamide, has just the cleanest kinetics there is. Essentially 7-day onset, 10 to 14-day nadir, and then roughly 21-day recovery. So a lot of these regimens are given every 3 weeks based on the cyclophosphamide kinetics. And our NCCN guideline for febrile neutropenia, kind of leading on neutropenia. So essentially any person with greater than 20% risk of developing febrile neutropenia is categorized as high risk. And there's consideration for growth factor, consideration for antibiotic prophylaxis. And so the greens are the platinums, and yellows would be alkylating agents. And you can pretty much see it's really dominates this list. So a lot of these patients will end up with growth factor. So a couple of small cases, and just to kind of get you thinking, this patient was admitted with febrile neutropenia, RCHOP. He's day 10, so we're going to really be expecting the nadir to happen here soon. ANC is 334, clinically stable. And the growth factor considerations are, there is the cost, of course, to patients. It can be really high copays. The adverse effects of bone pain, fevers that are temporally correlated to the growth factor shot, but still a patient having fevers at home can be very nervous and call in. And really, it should be taken seriously. But there's no free lunch with growth factor. So with RCHOP, you'll notice it's not in the high risk. It's not the 20% or greater. It would be intermediate, which is 10 to 20%. So it's important to assess, had this patient been started on Granix or not, or growth factor, either Neupogen or Negastem, one of the other, Zarxio, 4 different short-acting growth factor products that we use right now. And if they are on that at home, then we'll continue it while they're hospitalized. If they were on a long-acting drug, we generally we'll watch it, but you'd expect 14 days of activity with a long-acting drug. And then these are IDSA and NCCN guideline recommendations on when to start secondary prophylaxis if a patient has febrile neutropenia. So we'll see, full Fox. It's again an intermediate one, and we'll see severe neutropenia ANC of 30 or 40, and we'll generally start growth factor for those patients. That'd be the most common secondary prophylaxis, I'd say, is severe neutropenia, less than 100. But the other things are good to consider: pneumonia, invasive fungal infection, etc. There is a guideline locally, and then there'll be neutropenic guidelines on NCCN is probably the most comprehensive document. Moving on to nausea. And so kind of another image here that these agents are on the high risk end of the spectrum. So the 90% or higher will really throw the kitchen sink at to prevent nausea. And this is from the NCCN guidelines on the percentage of emesis. And so pretty impressive for these agents. We built all the treatment plans, all 220 plus that we talked about earlier, will have nausea prevention medications built in. And our guideline has our standards. So whatever hospital you work at, you generally have 1 or 2 choices for high risk, for moderate risk, and for low risk. So those approaches are followed as an institutional standard. We don't really kind of a stretch for other drugs unless there's an adverse effect. So a patient might have intolerable headaches with ondansetron, and we'll flip out to either palonosetron or granisetron. And it's not really about, well, granisetron, a lot of insurance companies in the area will limit this to 9 tablets per dispense, FYI. All right, the second case, just a kind of a nausea case. So we have this MTR patient. So temozolomide would be generally the offending agent here. Even methotrexate is not on the high or moderate end of the spectrum. The temozolomide for this regimen is given day 7 through 11, and he has nausea and such, and couldn't tolerate any oral intake. And so we ended up, this guy actually came to the hospital for fluids and stuff, left essentially the next day. But there's several tips for nausea. The ASCO guidelines has a really good patient handout sheet. The UW Health teaching sheet is actually pretty good. And then there is a pharmacy service for refractory nausea vomiting. So if somebody's calling you a lot, or if they're you're really struggling with what works best, there's a pharmacy delegation protocol. We'll watch the patients every single day and kind of work with you to establish the best medical care. But these tips really work a lot. So temozolomide, we always recommend to do at bedtime on an empty stomach. And since these patients were admitted, we changed the beacon treatment plan to have 4 milligrams of ondansetron before each dose, so 30 minutes before each dose. Start with that, see how you do. Some patients are great and they fly through and don't like ondansetron because it's constipating or induces headache. And so we say you can pull that off if you don't think you need it. Other patients swear by it, and it really works well for them. So these are common sense, but like patients will be eating 6 or 7 times a day instead of a large meals, and really small portions, like even a half apple or something will count as one of those 6 or 7 times. Prehydration, we can up the prehydration and if it's a cisplatin or something. Increase the prophylaxis, so you might go from the moderate prophylaxis to the high prophylaxis, like adaprepitant or adpalmosetron. Change chemo, we only do that in pillative attempt, but definitely with these metastatic cases on Temodar will be a common metastatic drug. We'll split it up. And here's the ASCO guideline I recommend. So it has slides. There's a podcast even. Different patients respond to different teaching methods, and same for providers and clinicians. These kind of supportive care are really quite good. And then Europe has their own guideline, ASCO has their own guideline, NCCN, and they all have disagreements. So there's not a standard approach across all 3 guidelines. But they also all add good value, and we use all 3 of them to build an internal guideline. Okay, so we're looking at, now we'll kind of go head to toe from here on out. So I had to get those 2 big ones in, which are really like the bulk of patients are going to be dealing with neutropenia, abnormal neutropenia, or nausea. So now we'll go head to toe with the rest of the talk. So this is a case, the black box warning case, where once every 12 months or so. This is a very common presentation. We had one patient that was actually a professor and really well spoken, and turned to this really aggressive kind of somnolence and agitation first, but then somnolence second. And so this is likely to, ICE has carboplatin, ifosfamide, and etoposide, and this event was likely related to the ifosfamide. And so this is from an accumulation of acetaldehyde, and like the electron transport chain depletes. And so essentially you have to replace that electron transport chain to get over the symptom. You stop the drug immediately. It's can happen with other drugs. Ifosfamide is by far the most common. This would happen. We only had one time without Teva, which I've been here almost 15 years now. I can only remember one case without Teva. The onset is tricky. Generally, it's within the first 3 days. You can feel pretty safe after the 3 days. And then every case I've ever had has at least 2 of the risk factors at the bottom. So with these black box warnings, almost all of them have a series of risk factors that are almost always accurate. So here it's, if somebody has hepatic dysfunction, renal dysfunction, or has hepatic dysfunction and albumin of 1.9, these are really, really high-risk patients for encephalopathy. And so you stop the drug immediately. You can wait a little bit to assess. Methylene blue, it's not like a stat emergency drug, but we generally start thinking about it right away. And if they don't clear up quickly, it's best to start methylene blue. The order it'll have 50 milligrams and then either Q4 or Q6 when you order it. So it's kind of nice that it points you in the right direction. But Q4 would be for treatment. And if somebody had liver disease and kidney issues up front, you can consider even not as secondary prophylaxis, but as prophylaxis up front. We've done that a couple times. We generally try not to, but if somebody does have this issue, they won't always go on to further therapy. A lot of the ifosfamide regimens are only 1 or 2 cycles anyway, so that kind of helps. But I would say about a third of patients we feel, well, let's say a half of patients, their liver improves, their kidneys improve, everything gets better with treatment. So then we can feel pretty comfortable going to the second round of ifosfamide, but we'll usually give a secondary prophylaxis with methylene blue. And that's what it looks like when you go to the bathroom. So the patients are always informed their pee will be blue, and that's normal. Peripheral neuropathy, so kind of pivoting to mostly platinum-related impacts. And there's a concept of acute incidence and persistent, some call it delayed, but really, persistent neuropathy doesn't really happen on its own. You'll have some sort of acute symptoms, and then persistent symptoms will develop. And I know you guys have seen this a lot, but for newer clinicians, the neuropathy is probably one of the most diverse presenting symptoms. People can have, first of all, their experience with it can be dramatically different. Some patients, we had this one knitter that it was really her whole life, her main hobby, and she was retired. And anything that impacted her ability to knit was just a massive impact on her quality of life. But you'll have people that can't, all the way to can't walk with this, can't move their arms, severe ADL limiting, where they can't do the dishes, they can't cook food, they can't button their shirts, they can't tie their shoes. So there's the fact that this is a dose-limiting toxicity is very important, and it needs to be assessed really pretty much every cycle of therapy. And so, yeah, we'll talk about later, but genomic biomarkers and drug labeling. And so we have the ASCO guidelines were published in 2020. It's about every 3 years or so they're updated. It's a little bit hard to see, but on the platinum's forest plot on the bottom, you do have about roughly a 20% to 30% help with duloxetine. And so duloxetine should always be the go-to drug for peripheral neuropathy, especially related to platinums. And so usually we started 30 milligrams for 7 days and then go to 60 milligrams. UW is pretty good about following this. Other systems that we interface with will often have gabapentin or pregabalin. And it's not bad to try. A lot of patients end up on both. And a lot of patients have probably some perceived benefit from gabapentin. So it's not something we don't do, but just be aware that duloxetine is the only medication shown to have benefit. And this 20% benefit might seem small, but to some people it makes all the difference, where they can really, it's worth a trial for most patients. Then we'll have stop and go with oxaliplatin. Not great evidence on it, but it still has some evidence. And you can see prevention has really been a failure. Like, it's a well-studied adverse effect. Like, a lot of different things have been tried, and we're still struggling. And so on this poll, kind of like with neuropathy, and everyone here has probably seen it, it's just a hard adverse effect to explain to patients. It can vary from numbness in your fingers to tripping downstairs, falling on a loose rug, having shoes that are uncomfortable. And so it's hard to detail all this information in your appointments. And other patient handouts can be really helpful, but I haven't found a good one for peripheral neuropathy. When patients have issues, we've definitely kind of presented that there's a lot of information here. Some of it might be helpful. So people will put up banisters, even in their hallways, like not just stairs, but hallways. They'll get different bathrooms and all that stuff. So it's a tougher, and then our drugs too, they don't work great like we have pretty good drugs for nausea, pretty good drugs for neutropenia, but the drugs here don't work great. But there's a lot of good ideas, and you can work with social workers and PT to kind of help get this message through to help patients. All right, moving down to lung. Busulfan lung would be, again, the original lung toxicity established in the 50s. Metabolites are known direct pulmonary toxins. So we'll see like a patient really probably every 2 years will be impacted from busulfan. Busulfan is really only used in heme BMT settings. And it's generally pretty sad. Like it might have been 2 or 3 or even 4 years from the drug use, but steroids don't work. Any kind of pulmonary therapies don't work. Going to transplant may or may not be an option. I guess hopefully more will continue to evolve on helping this adverse effect. But those are kind of the key principles, that it doesn't necessarily come on really fast, but the risk factors would be more drug exposure over time, and having a baseline lung function panels that are lower. Cardiotoxicity. So in the warnings, there are only 4 of these drugs. So like 4 drugs listed here, but so cardiotoxicity with alkylating agents, platinating agents isn't necessarily thought of at the top of the list, but Cytoxan is one of the drugs we use a lot, so it's really commonly used. And you can see here that there's 15 different of the warnings for cardiovascular are just cardiovascular warning, but then it'll go on and say arrhythmia, cardiomyopathy, effusion, heart block, heart failure. So it'll be 2 paragraphs of a warning about cardiac disease. Generally, this happens with higher doses, and historically, for breast cancer autologous transplants, we had a dose of 90 mg per kilogram. And that's where we really found that dose-limiting toxicity when 5% of those patients developed heart failure. And so we will never go near those doses now, but we'll still, 60 mg per kg in our post-transplant Cytoxan doses. People will get Cytoxan in different cycles. So it does happen, and we will see these issues a couple times a year. Liver toxicity, so the classic liver toxicity would be veno-occlusive disease, and busulfan would be the most common. We have had it happen with melphalan, I think, again, once in like 10 years. So, but yeah, again, a pretty rare effect, probably 1 every 18 months pediatrics has a higher incidence. They have probably 1 per year. And this classic triad is weight gain, upper quadrant pain, and then increase in liver function tests, which can be a little not specific, but you'll always see it in BOD. So we're watching that closely with the patients. Has a high mortality rate. We use defibrotide here for all patients. There is a guideline on defibrotide use. Again, you have your risk factors, radiation therapy, a lot of previous chemo, prior transplant, et cetera. So this guideline spells out how to use defibrotide. It's a really hard drug to dose and keep up on. It's every 4 hours. It has a really short half-life. It's very expensive. It's not fun for patients because they're getting hooked up to this constantly. And so, but I always go to the guideline to look at how to kind of dose it and adjust the dose based on platelets, or there's adverse effects with it that you have to kind of consider. All right, renal toxicity, hemorrhagic cystitis is something we'll discuss. So acrolein accumulates in the bladder. This leads to tissue edema, ulceration of mucosal tissue, and then it can invade the smooth muscle fibers. Here again, it's probably 1 case every roughly 18 months, I'd say. Not overly common because prevention of it works really well. The 10% incidence would be, with inappropriate supportive care. Any dose of hyphosphamide, that's why this is a black box warning for hyphosphamide. High dose cyclophosphamide, and then chronic, which we rarely do chronic cytotoxin. You'll generally see it in some immune condition and not cancer anymore, where we will see hemorrhagic cystitis, somebody that's been on 2 milligrams orally daily for 2 years, and their oral intake goes down, and you'll see hemorrhagic cystitis develop. So yeah, urinary frequency, sensation, burning sensation, all the kind of classic GU symptoms, I guess. For the high doses, it'll happen quickly. So within, so here, I guess here's the images that you can see the mucosal damage. The high doses, we test urine analysis for blood before the doses are given, and then daily for 2 days, just because if it's going to show up, it'll show up in 24 to 48 hours. But to prevent is really important, so we'll do a lot of IV fluids, at least 100 an hour, sometimes 150, and then using Mesna to bind the acrolein to prevent exposure to the mucosal surface. So like a CHOP type regimen, we generally won't use Mesna. It's good enough to either give a liter of fluids, or if you have a patient that's really, really good at drinking water, that's fine. Let's see, so here's a picture of why is hyphosphamide a problem, and it essentially, with its metabolic breakdown, it produces 5 molecules of acrolein for 1 molecule of hyphosphamide. So it's 5 times more toxic than cyclophosphamide. Cyclophosphamide would produce 1 molecule of acrolein for 1 molecule of cytoxin. It's the same for the active drug too. So you'll see hyphosphamide doses are 5 times higher roughly than cytoxin, because to get to the active drug, it's 5 times more. And then built in all our plans are, again, the UA, and then we'll have Mesna built in as well, either a 1-to-1 ratio with the drug dose, or 20% of the dose given before the drug, and then 4 and 8 hours after the drug. There is oral Mesna, but it can be expensive, and then only certain pharmacies have it. So make sure if you're sending a patient on this that they have insurance coverage for it, and then generally fill it here, because there's Walgreens and CVS don't stock Mesna. Mesna oral is double the IV dose. All right, so let's see, one more case here. So this is a sarcoma patient. So they've already had 1 megadose of cisplatin, 120 milligrams per meter squared, and her creatinine clearance isn't terrible, but it's not great. Magnesium has been impacted. Like we're going for a cure here. What do we think about with dosing this? And so the renal toxicity, it's hard to sort out who's going to have the problem. Like I really wish we had some sort of genomic marker or biomarker, but it's pretty challenging. Some 60-year-olds will generally be okay, and then 29-year-olds just totally fall apart. It's hard to predict. Really high incidence, black box warning again, moderate to severe, and then generally with more cycles, you'll have more toxicity. It doesn't happen when you're watching closely the first week, it happens the second week. So that's kind of an issue too. You can kind of lose some of those patients to follow up if they're not coming in or if they feel good. It's hard to like consider dose reduction, especially in the second cycle. There is some guidance in the package insert. So cisplatin especially has this range of 50 to 59, 40 to 49 per creatinine clearance. And that data is not from the initial studies. It's from like the ones with the stars are not from initial clinical trials, but added on later. And so only 5 of these 15 drugs have renal dosing guidance in the package inserts. Many of these studies are small. They're like 10 people, 20 people, maybe 30 would be a really good study. So we always kind of consider the whole patient picture. Like, are we really going for cure? Was there anything else that might have caused this kidney injury that we can correct now? Like if getting really good hydration this time and planning the patient to come, maybe the infusion center on a Sunday to get a liter of fluids, will that maybe help out? But you also got to kind of, if it's in the package insert, you really got to think about dose reduction. Sometimes we'll delay a couple days to see if the kidneys will improve further. There's no right answer. It's really it's a tough problem with alkylating agents because the data is not as good as we'd like it to be. And you'll see the ones without, these are all from LexiComp if it's not in the package insert, the recommendations for dose reduction. And so you can go there to see the exact study if you are interested in learning more. Yeah. And sometimes like in BMT, you can feel more comfortable. Like we're really just going for a marrow ablation. We're not going for curative disease with some of these agents. And so you can be a little more comfortable with your dose reductions. Whereas if you're going for a cure and like this is their one shot at it and they're 29, you might be a little bit more aggressive. All right, hypersensitivity. And so again, carboplatin is up to 16% of patients. This is another one that I for these symptoms, there's different recommendations for PRM medications. And so we have a hypersensitivity guideline to treat these symptoms that arise. I don't memorize like what do you use for highs, what do you use for swelling. It's kind of spelled out nicely, but at the same time, as long as you do, like, it doesn't really hurt to just throw the kitchen sink at them and get them through the initial process. It's always kind of amazing how well the medications work to help, but it can be really scary. And this will often happen in clinic where there may or may not be as much nursing staff to help out. In the table here, so we have, hives, you do diphenhydramine plus famotidine, oxygen, get oxygen on them, of course. Hypotension, you want to throw Dex at them, and a bolus. So this is a guideline I'll also just keep favorited and really quickly look at it before verifying the orders. And then there's also a hypersensitivity order set that you guys can use. Use it, save it as a favorite if you would like. Just be really, like with oxaliplatin, if you're prescribing that, just kind of know that it's going to happen to you at some point. And then we have the desensitization protocols. Mike had kind of mentioned this yesterday, but this is built in for carboplatin since we use it so often. So they'll start, these are 3 different concentration bags, and then you'll go over several hours, so 8 to 12 hours to get the dose in to desensitize, and then in the future you can go go back to a standard dose if well tolerated. Some patients will have to use this protocol multiple times. And then hypersensitivity is one thing too that you'll see it happen more the more cycles you get. So it's not like a rituximab where you'll see rituximab reaction the first cycle, but then their lymphocytes are controlled and you don't have to worry about it again. With carboplatin, it can happen increasingly the more it's given. Really quickly, just wanted to point out a real variety of dosage forms here. And so TEPA will be, intercavitary, like a pleural effusion dose. The carmazine implant wafers are for, glioma, brain cancer surgery. They'll put the wafers right in there. Mecloramine, we really only use topically nowadays for like T-cell lesions that are really localized. It just has too much of a secondary cancer risk. The drug interactions, not all these interactions would be in the package insert. So not all of this class has drug interactions. I think a class effect is if you use it with other myelosuppressive drugs or other immunosuppressive drugs, expect more issues to happen, like infection-wise. So busulfan, if somebody's on posaconazole or voriconazole, we'll try to stop it before giving busulfan. We definitely won't be giving it at the same time as we're giving that drug. On the genomics picture, let's see here. So now, Lauren, do you know how many oncology drugs have precision medicine guidance in the package insert now? Any guesses?
I don't know, like 15?
Yeah, it's up to 120.
Oh gosh, that was way up.
So, yeah, I was actually surprised because last year it was 65. And so there's been a lot of work on that over the last, and then the year before it was like 42. So 42, 65, 120 today. And so yeah, cisplatin has some guidance with TPMT and autotoxicity. Busulfan has really old guidance that it doesn't work good for Philadelphia chromosome positive CML. So it's like this really kind of old, now that we don't treat CML with busulfan anymore, of course, we do the TKIs. But, so a lot of the genomic stuff we have is from the 80s or 90s for these drugs and is not as applicable as you would like. But I still think there's going to be more coming out on how these, for instance, like azacitidine works really well for RUNX1 patients. So I think that'll make the package insert if we can get some more data to support that, and that kind of stuff will continue to evolve. But yeah, kind of exciting. All right, that's all I had. Is there any questions at all, or?